It's my great pleasure to introduce, Dr. Raphael Stricker from Alan E. Beer Medical Center for Reproductive Immunology. As Ken also said, we know at least Dr. Beer, we knew him for how many years. And he will definitely tell you about, his output on autoimmune responses in women with reproductive failures. Okay, it's a little bit tricky, as Ken said, This is the, whatever. Yeah, and this is
That's forward.
to forward. Then you're going to go backward, this is the button. So.
I think I got it.
Okay.
Thank you very much. It's a pleasure to be here. I'm encouraged that I've heard Dr. Beer's name so often, so you're all familiar with him. And I'm going to talk today about autoimmune responses in women with reproductive failure. The first two speakers have actually explained my entire talk, but I'm going to do it in a much simpler way because I'm just a simple clinician, and I like to think of these things in terms of ways that we can address the issues. So first of all, the only disclosure that I have is that I am the medical director of the Alan Beer Medical Center for Reproductive Immunology, which is in Los Gatos near San Francisco. Dr. Beer, as you know, have heard, was a visionary who looked at multiple factors in reproductive failure, and he liked to show off his successes at an annual picnic every year. But in terms of recurrent pregnancy loss and recurrent implantation failure, I'm going to talk about what the problem is, pathogenesis, diagnosis, treatment, and future directions. And I'm going to limit my talk to autoimmunity today. If you look at my talk from last year, I gave a more comprehensive talk about our experience at the Beer Center. But today I'll try to limit it to autoimmunity. Now, what's the problem? Well, the problem is as women get into their 40s, the miscarriage rate approaches 75%. IVF is the cure, right? But it turns out in these women, the success rate with IVF is really only in the 20% range, not that great. So there are obviously other factors that are involved that are interfering with pregnancy. What are those factors? Well, to get recurrent pregnancy loss or implantation failure, really two sides of the same coin. These patients have similar ages, similar histories of pregnancy failure, and also similar immunologic, metabolic, and coagulation abnormalities. And you've seen various variations on this theme of the immune balance in pregnancy with Th1 and Th2. This is a 25-year-old slide, but it's still somewhat valid, even though you've also seen how complicated the immune system is in pregnancy, as shown on this slide, and I hope you're all going to memorize this slide. But I think it's still useful to think of immunology of pregnancy in terms of humoral immunity and cellular immunity, with humoral being autoantibody production, cellular immunity being cytokines and cellular T cells and other cells that affect pregnancy. So what kind of testing is available for this? You've heard about some very sophisticated ways to do this. Again, I like to do a much simpler kind of profile for our patients. For cellular immunity, we look at leukocyte antibody levels. Interestingly, this is an antibody that's not pathogenic, it's actually protective, whereas the other factors here are potentially pathogenic, with high natural killer cells, low T regulatory cells, and high Th1, Th2 cytokines. And the numbers here are the percents in our cohort of over 1,400 patients that we've treated over the last 15 years. In terms of autoimmune testing, autoantibody testing, these are the autoantibodies that we look for: antiphospholipid, antithyroid, antinuclear, anti-DNA, and anti-ovarian antibodies. And then there are two other conditions that are interestingly associated with autoimmunity, which I'll talk about: polycystic ovarian syndrome and also endometriosis. I think I left some water here. Okay, so leukocyte antibody testing looks at maternal anti-lymphocyte antibodies to paternal HLA antigens. These are IgG antibodies directed against T cells and B cells, and they're detected using flow cytometry as shown on the slide. And I'll get back to that later. For natural killer cells, there is this spectrum from normal pregnancy with normal CD56 natural killer cells and normal NK cytotoxicity over to pregnancy failure on the right with high CD56 natural killer cells and high natural killer cell activity. And this is what we look for in women with recurrent pregnancy failure. For T regulatory cells, you just heard a very elaborate discussion of Treg cells. We tend to look at the basic Treg cells, FOXP3, CD25, and pregnancy success is associated with the level of these cells. As you can see here, 80% success when cells are high, 40% success if they're low. And then for cytokines, we look at the Th1, Th2 cytokines, and there again is a spectrum between normal pregnancy, oops, did that too, with normal cytokines, normal IL-4, 5, and 10, versus IVF failures with high cytokines, predominantly tumor necrosis factor, which is the one that's easiest for us to measure. So now, what about autoantibodies and miscarriage? Well, there are a number of studies showing a correlation between autoantibody positivity and the number of fetal losses. The big question here, though, is are these autoantibodies pathogenic? Do they cause the fetal losses? Or are they just markers of pregnancy failure? And that is a question that you'll see throughout this presentation. And to my knowledge, there's really only one autoantibody where that's been answered, and I'll show you that in a minute. So the one where it has been somewhat addressed is antiphospholipid antibodies. And as you heard, there are 3 classes of antibodies, IgG, A, and M, and then there are 6 phospholipids that are tested. Antiphospholipid antibodies are associated with failure of the syncytial trophoblast and then a pregnancy failure, so that's thought to be the mechanism. For testing for antiphospholipid antibodies, and this slide is very important, it's not enough just to do an antiphospholipid antibody screen. If you do that, and that's shown on the left here, these 2 columns, you will probably end up with a negative test. You have to test for specific antiphospholipid antibodies in order to see if they're there. So this is a very important clinical point. Don't just do the screen. Do the whole panel looking for these antiphospholipid antibodies. Now, which antibodies are important doesn't really matter. This study showed that in 77 patients with antiphospholipid antibodies showed that basically all of them are significant and are associated with recurrent miscarriage. There isn't really one that's better than another. And then this is a study from a long time ago by Yehuda Schoenfeld's group where he gave normal mice, normal pregnant mice, either mouse antiphospholipid antibodies or human antiphospholipid antibodies, and showed that in the mice, the control mice, you see the normal embryos down here on the bottom. The mice who got the antiphospholipid antibodies had this shriveled up uterus with destruction of their embryos. So this is probably the best evidence that these antibodies are pathogenic and can interfere with pregnancy directly by destroying the embryos. So now thyroid disease is very important in pregnancy for both the mother and the fetus. This is a review by Stagnaro Green from a number of years ago, looking at 5 studies that showed that antithyroid antibodies are significantly correlated with recurrent miscarriage. Now again, is it pathogenic? Are these antibodies pathogenic? Or are they just markers of miscarriage? Hard to say. In terms of anti-nuclear antibodies, there are a number of different types as shown on this slide. This is a meta-analysis by Cavalcante and colleagues, and I'm sure they're going to tell you more about this, showing that there's a significant correlation between anti-nuclear antibodies and miscarriage with a 3-fold increased risk of miscarriage when these antibodies are present. Again, are these pathogenic antibodies or just markers of miscarriage? Hard to say. Anti-DNA antibodies have been described. There are a number of those. And drink. And here we have some interesting finding for the rheumatologists in the audience. In a study done in lupus patients looking at anti-RO, which I believe is now anti-SSA, when these antibodies were present in lupus patients, there wasn't any increase in miscarriage. But when these antibodies were present in non-lupus patients, there was a significant increase in miscarriage. Now, why there is this difference between lupus patients and non-lupus patients who have these antibodies is hard to say. Perhaps the non-lupus patients have early autoimmune disease, and we're just detecting that by looking at these antibodies. Anti-ovarian antibodies in pregnancy have been associated with a number of problems, and I think you heard a little bit about this yesterday. However, the problem with these antibodies is that studies that have been done looking at pregnancy loss with these antibodies have basically been inconclusive. There's no significant correlation between these autoantibodies and pregnancy loss, so it's very hard to say what these antibodies are doing in specific patients. And then two other syndromes that are kind of interesting. Polycystic ovarian syndrome we know is associated with endocrine problems and various diseases, but what's also interesting is that polycystic PCOS has been associated with a number of autoantibodies, and shown on this slide, what the relationship is between PCOS and these autoantibodies is unclear, but PCOS is also associated with recurrent miscarriage. It may be related to these autoantibodies. Endometriosis, as you probably know, is associated with a number of cytokine abnormalities, but it's also associated with a number of autoantibodies as shown on this slide. And in fact, some of these autoantibodies are very esoteric. I've never even heard of them, and it's really hard to say what they do. But it is kind of interesting that a disease that we don't really think of as autoimmune is associated with autoimmunity. So how do we treat this? This is the treatment for various aspects of autoimmunity for the low leukocyte antibody level and other cellular problems. We have lymphocyte immune therapy, or LIT, and also intravenous immune globulin, IVIG, and dexamethasone. For the cytokines, especially high tumor necrosis factor, we use adalimumab as a mainstay of treatment. For the autoantibodies, we use primarily IVIG and dexamethasone to suppress those autoantibodies. And for patients who have antiphospholipid antibodies, we also add in an anticoagulation regimen such as baby aspirin, enoxaparin, and dexamethasone to avoid the excess blood clotting due to these autoantibodies. Now, lymphocyte immune therapy, the principle of LIT is that the prospective mother is immunized with cells from the prospective father, and that then boosts these so-called blocking antibodies and helps the pregnancy to proceed. LIT is still not approved by the FDA. It's done pretty much everywhere else in the world, from Canada to Mexico to Brazil to Germany to Italy to India and China, but not here. And I think that is a problem that at some point has to be addressed. So when you do LIT, looking at these leukocyte antibodies, usually women start out with a very low level, something like less than 5%, with a normal range, desired normal range of about 50% or more. With one course of LIT, the levels go up to maybe the 30 to 50% range. And then with two courses of LIT, usually you get 89 to 99% positivity of these leukocyte antibodies, which is optimal for pregnancy. Again, you'll hear a lot of people say, well, LIT, it's really unproven. You know, somebody did a study 20 years ago that showed it didn't work. But this is a meta-analysis by Cavalcante's group, looking at studies of LIT, and what it shows is that there is a threefold benefit to doing LIT in terms of the odds ratio of pregnancy success. So this really looks like, on balance, a very positive treatment. The problem is the FDA focused on this one study by Ober from the NIH, which was a negative study because of poor technique, and that's the reason why it's not approved, still not approved in this country. Intravenous immune globulin, IVIG, has been around for decades. It has a number of effects on the immune system, which I don't have time to go into. It has been used for women with recurrent miscarriage. And again, you'll hear what people say, well, you know, they've done those studies and they were negative and IVIG doesn't work. So when you hear that, you should look at the studies that were done. And there's basically two kinds of studies. There's failed IVIG trials and successful IVIG trials. And the difference is shown on this slide. Failed IVIG trials had younger patients. The average age was 31.9 years. They excluded women with immunologic abnormalities, which is kind of ridiculous. The initial IVIG treatment was done following conception, and IVIG was given at non-physiologic intervals during pregnancy, usually like 1 to 2 weeks. Now, in contrast, successful IVIG trials, the women were older. The average age was 36.4 years. They included women with immunologic abnormalities. The initial IVIG treatment was generally given prior to conception, and IVIG was given at physiologic intervals during pregnancy every 3 to 4 weeks. So again, when you hear discussion of IVIG trials and how it doesn't work, think about this slide. Think about what the successful studies were versus the unsuccessful ones. Adalimumab, or Humira, is a fully human anti-tumor necrosis factor monoclonal antibody that has a long half-life, up to 2 weeks, so it can be given at 2-week intervals. There's recently been a biosimilar approved for Humira called Amjevita. Nobody seems to have much experience with this, but the HMOs like Kaiser are really big on it because it costs about 10 cents less than this brand, and we're kind of waiting to see if it'll work as well as Humira. There has been concern about safety of anti-TNF therapy during pregnancy, but 2 recent studies showed that this treatment is safe during pregnancy in terms of fetal toxicity, lack of toxicity, if it's given during pregnancy. And then dexamethasone is a steroid medication, as you're all familiar with. We like dexamethasone better than prednisone because it has less side effects than prednisone in terms of fluid retention, hyperglycemia, hypertension. It also has a slightly longer half-life than prednisone, so that may be an advantage when it's used in pregnancy. And dexamethasone is part of the regimen for anticoagulation with baby aspirin and enoxaparin in women who have antiphospholipid antibodies and also other risks for hypercoagulability. Okay, what about treatment results? Well, I don't have time to go through all of our different patient groups. I did that at the talk last year, so you can look at that if you're interested. I only want to talk about the overall success with these over 1,400 patients. The age at conception for these patients was 37.8 years, with very few successes and an average of 4 prior miscarriages or IVF failures. And in terms of treatment, with no treatment, the success rate with the historical control group was on the order of 23%. So pretty bad, even with IVF. Giving baby aspirin and enoxaparin, the success rate goes up to 28%, which is not significantly better. But adding IVIG to the anticoagulation, you get to 64%. And then adding LIT plus IVIG, you get to 70% success. So these treatments that address autoimmunity in women with recurrent pregnancy failure have been quite successful in our experience, and we continue to do these kind of treatments. So just in conclusion, recurrent pregnancy loss and recurrent implantation failure are significant problems in older women attempting pregnancy. Autoimmune abnormalities are associated with RPL and RIF in these women. Treatment of these abnormalities is associated with a significant increase in pregnancy successes. Further studies are needed to evaluate the diverse components of the autoimmune response in these patients. And Just for future directions, it's time. It's time for the FDA to look at LIT and approve it. It's been around for years. It's being done everywhere in the world, which should be done here. Insurance coverage for IVIG and adalimumab, which can be outrageously expensive, should be much better. And improved immunotherapy for NK activity would certainly be desirable. You heard about tacrolimus yesterday. You're probably going to hear about other things today. That would be nice. Understanding triggers of autoimmunity is very important. And then broader recognition of immunological factors in recurrent pregnancy failure would be helpful. So I'd just like to acknowledge my coworkers, especially the late Jerry Trobaugh, who really kept the practice together after Dr. Beer died, and then all the others that we've worked with. And here are the references for what I've talked about. And actually, I went through this too fast, probably, because I have too much time left. And thank you very much for your attention.
Any questions?
Thank you very much. That was very interesting and informative talk. I have two questions. First, what did you mean by saying physiologic intervals for IVIG? How long that is?
So the half-life of IVIG is 21 days. So physiologic intervals would be 3 to 4 weeks when it's given.
And do you need to check some parameters while you are administering IVIG?
Well, it depends what the indication is. I mean, if there are these autoantibodies or immune factors, we follow that, we monitor that during the pregnancy, usually on a monthly basis, and we adjust the treatments according to that. For example, if patients have very high NK cells or high NK activity, we'll treat them with IVIG until the NKs and activity go to normal, and then we can stop the treatment. So we do monitor those parameters during the treatments.
And similar question about TNF, adalimumab. So you mentioned about like 2 weeks intervals, and then do you stop it as well as IVIG, like once the parameters normalize?
So we've been influenced by the older literature that claims that adalimumab is toxic to the fetus. So we have not been giving it during pregnancy. We've only given it pre-conception. And the way that we'll do it is we'll look at usually TNF levels. That's the easiest thing to measure. And we treat patients for over a month, so basically 2 shots over a month, and then see what happens. And usually the cytokine levels go down. If they don't, you can repeat the treatment for another month. But usually we do get that under control with that kind of treatment prior to conception. Adalimumab is now about $7,000 a shot. So practically, it's just impossible for some patients to afford. It's unclear what Mgivita is going to cost, but I have a feeling it's not going to be a lot less. So we'll have to see how that goes.
And sorry, last question about preeclampsia. You mentioned that dexamethasone is much preferable than prednisolone. So we know that there are reports saying prednisolone causes preeclampsia. What about dexamethasone?
That's a good question. I really don't know. I haven't seen any literature about a difference in preeclampsia, but certainly our patients who are on anticoagulation with dexamethasone, we usually stop after the first trimester if everything looks better. And so it doesn't seem to affect preeclampsia if that happens. It's more related to older age. That's the biggest risk.
Thank you. So I missed some of your talk, George and Duga from London. I noticed the difference between your use of dexamethasone in the US and we use mainly prednisolone in the UK. The reason being that dexamethasone 70–80% will cross the placenta, and my colleagues who are going to look after the babies are really concerned about that. And we don't see quite a significant amount of fluid retention. Obviously, it depends on how much one is using, but we don't seem to see quite a lot of that. And on the second point about safety of Humira, there was a study done by, I think it's the rheumatologist, published in one of the journals, which I happened to come across. They looked at women who had rheumatoid arthritis or Crohn's disease, who couldn't be taking off the Humira during pregnancy. And it was quite reassuring but they didn't see any difference at all in any effect on the babies and outcome of the pregnancies.
So let me go backwards. The studies on Humira, there were two studies, one in the Annals of Internal Medicine and the other in PLOS that was published recently. Both of those found exactly what you just said, that it didn't seem to affect pregnancy in women who had rheumatologic disease and who were on those treatments and couldn't be taken off them and got pregnant. So yeah, so it does look like you can give it during pregnancy. The first question, we use very low doses of dexamethasone and we don't really see any toxicity with those doses. Certainly higher doses could be toxic to the fetus, but with our doses, we have not seen any problems using those low doses as part of the anticoagulation regimen. And the dexamethasone does help in terms of the anti-inflammatory effects.
Thanks. Great talk, as usual, Ralph.
Thank
Really
you.
good. Just to enlarge upon the question of when do you stop autoimmune treatment? Somebody alluded to it just now. For example, the problem I have, we've been treating, looking at Hashimoto's disease, obviously need anti-autoimmune treatment. We picked IVIG. So you go on and you get to 16, 18 weeks, you think, it's expensive, should we stop it? But you've still got the autoimmune disease. You've still got Hashimoto's. It has late pregnancy problems, even stillbirth. And now I wonder how you approach this problem of when to stop with people who have underlying autoimmune disease.
Yeah, that's a very good question, and it's easier to answer for some of these factors than for others. Like I said, for the natural killer cells, when they go back to normal, then you can probably stop. For the autoantibodies, if they're persistent, and especially with antiphospholipid antibodies, if they have persistent production of these antibodies, we will continue the anticoagulation and the IVIG as long as it takes, and we can do it through the whole pregnancy. We've done that with some patients. With antithyroid antibodies, again, you get back to this question, are these pathogenic antibodies or are they just markers of disease? And if you correct the thyroid function, that may be enough. You don't have to do anything more. But we like to see those autoantibodies go to zero.
Except it's been shown that, you know, the actual treatment, levothyroxine, doesn't help. So you treat with anti-autoimmune treatment. But there's a basic underlying disease. And if you stop it, you know, you say, okay, 26 weeks, we're stopping it. And also when they now look at this pathology, and you have things like certain histologic findings, and you treat with IVIG for chronic histiocytic enterocolitis, when do you stop it?
Yeah,
do you come up with this problem?
Yeah, thyroid autoimmunity is very difficult. We're usually happy if the thyroid function normalizes. That's usually how we gauge whether the treatment's worked. It's nice to get rid of the autoantibodies, but we can't always do that, especially if they're very high level. But at least if we have normal thyroid function, we're happy with that.
Okay, we have time for two more quick questions.
On the same topic of anti-thyroid antibodies, as you mentioned that whether they are cause or effect, we don't know, or just coincidental. Is there any role of any immunosuppressive or agents in presence of anti-thyroid antibodies? There are certain centers who use azathioprine. What is the role of azathioprine?
Well, azathioprine is a chemotherapy drug, and I think a lot of OBGYNs are kind of reluctant to give it to pregnant women. Certainly there are other immune modulators that could be used. We haven't really seen much more success with them versus IVIG and dexamethasone. That seems to be the backbone that works the best. And usually these women do clear their autoantibodies, especially if they're low level. They do tend to go away. And also their thyroid function normalizes when we put them on thyroid medication.
Dr. Stigler, we will have a discussion during lunchtime about treatment and investigation in RI, in recurrent abortion and implantation failure. But I would like to ask a question. What are the steps we should take to have the FDA approval of the LIT?
Yeah, that's a very good question. The FDA in the past has required 2 studies done in the United States in order to approve LIT that shows that it is both safe and effective. Studies like that, if they're done properly, cost several $1 million. And since LIT is not a blockbuster drug that's going to be making billions of dollars for Pfizer, there's nobody who's going to fund that other than perhaps some charities that might do that, but we haven't found anyone to do that so far. But that's basically what they require.
Okay, one last question.
Thank you for the wonderful talk. So just a quick question following those questions regarding IVIG and steroid use. So a lot of patients with autoimmune disease, they show up and already on long-term IVIG and steroid. How do you evaluate those patients in that setting? Do you adjust the dose of IVIG and steroid according to the immune profiling? And if you do, how do you actually do the result interpretation because they have a baseline abnormal immune status already?
Right. Well, we don't really see that many patients who are on long-term IVIG and long-term steroids anymore, especially steroids, which now everybody's trying to avoid because of the side effects. So this is usually for short-term treatment in women who are pregnant, not so much for women with autoimmune diseases who might be on these treatments. In those cases, we try to work with the rheumatologist to kind of modulate the treatment to make it more effective. But it's hard to give a blanket answer to your question because, to be honest with you, I can't remember a patient I have seen who's like what you said.